Hi.
Hi, can you hear me?
Yes.
Oh, perfect. Okay. Now what I'm doing is just going to plug you into the screen. Can you try sharing your screen to see if that works?
Yeah. Just a second.
Yeah.
This is good.
Perfect.
Yeah.
Perfect. And so I'm just going to get that all ready and plug you in. And so we'll get started in just a few minutes. Trying to just leave that there, make sure we're all ready. And then Louise will introduce you and then we'll give you sort of the signal to get started. So just give us 2 minutes.
Yeah.
Thanks. All right. Good morning, everyone. We're a little slower this morning. We had the dinner last night. Maybe we had too much to eat. We're still digesting all that type of stuff. So welcome to the second day of the conference. It's my pleasure to have Reetika here to give our plenary session this morning. I'll let Louise come up and introduce her. If there's any questions after the presentation, you'll have to come up here, otherwise it'll just be a voice from the crowd and it'll be maybe a little bit confusing for our plenary speaker. So don't be shy. I'll come and help facilitate, but I'll pass it over to Louise now.
Hello, Reetika. How are you doing? And
Hi.
thanks for joining us. What time is it in India at the moment with you?
It's getting to 10 o'clock at night.
It's 10 o'clock.
Almost.
I think the sound is not great.
Yeah,
so,
You
well,
need me
thank
to
you.
speak up?
We're not hearing you very well, but
give me 2 seconds, Reetika. I'm just going to make sure our sound is okay and turn it up here. Would you mind just saying a word or two?
Hello, hello.
Okay, that's a bit better. Let's put it up the whole way. There we go.
right. Well, nice to see you again, even though virtually, and I'm glad you can join us this morning. So I'm going to give a brief presentation bio, and if you want to add anything to what I say, please do. So I'm really happy to present Reetika Khera. She's a professor of economics at the Indian Institute of Technology in Delhi, India. She studied at the Delhi School of Economics and the Institute of Development Studies at the University of Sussex. She's also did some postdoctoral research at Princeton University, and she was the visiting chair professor at the ICCR-King's India Institute at King's College London in 2016, and in 2017 the international visitor at Stanford Humanities Center, Stanford University. And in 2020 she was awarded the Malcolm Adiseshaiah Award for Distinguished Contribution to Development Studies, so development economist. So again, it's interesting because we're here from different backgrounds, and so the interdisciplinary nature of our presenters, I think, is of interest to the Health, Wellness and Society Network. So I'm very happy that you accepted our invitation. Her research is focused on social policy in India, and she's published wide and very extensively in a number of professional journals, magazines, edited volumes, peer-reviewed journals on issues of food security, health, child nutrition, employment, education. She's also worked specifically on technology and welfare. So obviously with the digitalization theme, we're very interested to hear about that work, which resulted in an edited collection entitled Dissent on Aadhaar, Big Data Meets Big Brother. So thank you very much, and we're really excited to listen to your presentation on the underbelly of digitizing healthcare in India. Many thanks.
So let me start by thanking Louise for inviting me to talk today. On the one hand, I feel sad that I'm not there. On the other hand, I think it would have been a long way to fly to give a talk. It would have been nice to meet this community of researchers who are interested in health-related research. But perhaps there'll be another opportunity. Just quickly to add to my own background, my training was as a development economist. And within that, I've been working mainly on all these different issues that Louise mentioned. And around 2009, 8 or 9, in India, there was this big push to bringing Aadhaar. It's the unique ID, which I'll talk about also. And the purported reason for bringing Aadhaar and giving everyone a unique ID in India was one of the important reasons given was that it would improve the administration and implementation of welfare programs, of social policy initiatives in the country. And that's when I got interested in digital and technology, use of digital technologies in welfare. And that's what I'd like to talk about. I think you can see my screen already. So maybe I'll just put it on presentation mode. I thought what I would do is first, because I'm not familiar at all with the people who might be listening in. So I thought maybe and I don't know how familiar you are with healthcare systems in India and the way it works. I thought first I'll set the context a little bit. And then through 3 case studies, I thought I would highlight what I think is the underbelly of these digital initiatives in healthcare in India. So let me first start by setting the context a little bit. One is that I think one important feature is that healthcare in India is very heavily privatized, and it's very fragmented. And in that sense, both in the high levels of privatization and in terms of the fragmentation, it's much more like the US system than the French, the UK, the German, or the Canadian models, which are quite, I mean, they're not similar across these countries, but the Indian system, if it has to, if you have to set some kind of parallel, it would be much closer to the US system. The levels of government expenditure, of public expenditure on healthcare are very low. As I said, privatization levels are high, and there's a very substantial private health insurance industry. So just, I hope the slide is moving for you as well. If someone could just confirm.
Yes, they are.
Okay, great. Thank you. Right. So just to put it in comparative perspective, I picked Brazil because India is part of the BRICS group of countries. And so this just to tell you where we stand in terms of public expenditure on health, it's about 1% of GDP, and it's been stagnant at that level for decades now. In comparison, Brazil is at about 5% of GDP. Out-of-pocket expenditures in India are very high, more than 50%. They used to be even higher, but they've come down a little bit from about 60-ish% to about 50%. In Brazil, it's about 20%. And health indicators are not great. It's not that the expenditures are low because Indians are very healthy. In terms of infant mortality rates, it's 26 per thousand compared to just 13 in Brazil. Life expectancy is lower in India by about 6 years compared to Brazil. And then I thought maybe I should just to, sometimes numbers don't really convey the kind of the kind of situation that we're dealing with in healthcare. So I put together 3 slides with some photographs to just give you a sense of what it's like. So this is at the district level almost. These are the kinds of facilities you have. And you can see that this is a pretty busy hospital, district hospital, government hospital. This one is showing you the next lower rung, which is more rural. And you can see that in spite of very difficult circumstances and very basic facilities, people are still trying to keep things going. So the image on the right is a primary health center that's flooded because it was the monsoon and there was water seepage issues and leakage from the roofs. A similar problem with the one on the left as well. But still, people, the health staff, frontline workers are rising to the challenge to the extent that they can in these difficult circumstances. And then you have, the ugly, as I call it, very non-functional, completely non-functional health facilities, public health facilities, where even basic infrastructure is missing. And this is not just a story of poor infrastructure, even staff. There are issues related to paucity of staff as well as work ethic, work culture related issues, which means that they're often absent or they're not appointed at all. So this is one part of the context, which is the kinds of challenges that the healthcare systems, in terms of healthcare systems that we face here. And then the second part of this context setting is related to the extent to which Indians, as on the whole, are able to participate in digital kinds of initiatives. I mean, this is true of many different aspects of our life, that more and more is getting live more and more aspects of our lives are getting lived online and through these digital technologies. And often India is seen as like a front runner in many of these things, and indeed it is. But there is a lot of inequality in terms of access, and this slide I wanted to sort of bring some of those to your attention. So the literacy rate in India is not yet universal. This is data from 2018. If India had conducted the census, then by now we would have had the 2021 figures, but India has failed to conduct the census for the first time since its independence. So 74% of Indians were literate. Adult literacy rate was 74% in 2018. Of course, it's improved since then, but still. Percentage of individuals using the internet was at about 46. And just for comparison, in Brazil, for the same years, literacy rate was 95%, and percentage of individuals using the internet was 80 plus. This is the all India average that you see on the screen. But within the country, there are a lot of disparities, men versus women, rural versus urban, and across states as well. So there's a national sample survey data, which is supposed to be nationally representative. And they had information in 2018 again, on the proportion of rural Indian women aged 15 and above who used a mobile phone at least once in the past 3 months, and was just half of all rural Indian women. And then you can see the contrast. Chhattisgarh is one of the central states, and Mizoram, which has 90% usage, is one of the northeastern states towards the northeast. And then if you set the benchmark just a little bit higher, they were asked whether they could send emails with an attachment, then the All India average drops to 7%. And you can see the range. The lowest was Madhya Pradesh, again in central India. And Kerala is known to be one of the front runners in the country in terms of all these social and development indicators. So this is again just to show to what extent in the Indian population is ready and able or capable of participating in digital initiatives generally. And these same challenges would, of course, sort of arise in the case of health access to healthcare, to the extent that it's mediated through digital technologies, which is why I wanted to mention these over here. So I'll move to the second part of the presentation. And what I thought I would do is to use these three case studies to illustrate a range of issues that are arising from the push for digitizing healthcare. Digitizing healthcare, of course, has many different dimensions to it. So I'm not going to talk about telemedicine and things like that. But I thought I would talk about two case studies which are related to the COVID pandemic. The first one is Arogya Setu, which is it's just the name of an app. It was a COVID tracing app, relying primarily on smartphones, but they said that actually even certain regular mobile phones, if they had a certain kind of Bluetooth installed, could be used. So basically, this was just a COVID tracing app. I think many countries develop these kinds of apps to help, in their disease surveillance efforts when the pandemic broke out. The second digital initiative is CoWIN. It was the digital platform that was used for registering people when the vaccine was made available. India started vaccinating its population in around mid-January in 2021. And this portal was set up to allow people to register and to find so basically on the one hand, they had all the hospitals and other health facilities that were empaneled to vaccinate people, and then the availability of slots. It was a pretty chaotic time. I don't know how it panned out in other countries, but in India, most people were frantic to get vaccinated and to be, ahead in the queue. The government had put in place a sort of priority list in terms of who would get it first. So like frontline workers were right ahead. And then it was opened up to other sections of the population depending on their vulnerability. But basically, there was a mad rush to get vaccinated, and the supplies were just not able to keep up. And that created the need to put in place some sort of queuing system. And in a certain sense, the CoWIN app, the CoWIN digital platform was meant to do the kind of rationing and queuing for the government. I'll explain a little bit more as we go along. And then the third one is Aadhaar, which already Louise mentioned. I have an edited book which talks about the problems related to this unique ID that the Indian government started giving out in 2009. This, of course, predates the pandemic, but it kind of acquired a new life and new meaning because of the pandemic, and also morphed into something else. So I'd like to talk a little. And these things are also interrelated because Aadhaar is basically now, the unique ID number is now sort of mandatory for almost everything in the country. It's a long story, but I try not to spend too much time on it because I tend to talk too much about it anyway. So I thought I would use these three digital health related initiatives as case studies to talk about these some of the emerging and existing issues with their use in health for healthcare in India, and the issues that have arisen because of the way they are designed and implemented are listed, or at least some of them are listed on this slide. These are the ones that I'd like to talk about today. So one is issues of exclusion because people don't have access to some of these or are unable to access because of the digital nature of these facilities. Uh, the other one is that they tend to exacerbate inequalities. I think a lot has been written about the digital divide. And so I thought maybe I'll talk a little bit about how these technologies are contributing to exacerbating inequalities in India. The third issue is related to lack of consent. There's, to ask for informed consent is tall order in India. There's actually really weird notions of what consent amounts to, and I'll discuss that, and also its consequences. Then there are data security issues, which have actually one of the biggest data breaches happened when I first met Louise in June this year while I was visiting. And what are the consequences of this? Another one is issues related to data mining, surveillance, and other privacy harms. And finally, most importantly, I think, is that all of this, all of the emphasis, there's too much emphasis on the digital aspects or on digitizing healthcare. And that is actually leading to a displacement of more important health efforts. So I thought maybe I'll go through all of these issues and use these three: the Arogya Setu tracing app, CoWIN, which is the digital platform for registration, and Aadhaar, to illustrate how these are contributing to the problems listed here. So as I said, just to give you a bit more context about these three initiatives, Arogya Setu is just the tracing app that was used, and similar versions were used elsewhere in the world. It relies on the fact that, I mean, the assumption, so the purpose is to help trace people who may have been exposed to COVID. And the way it would work is that the assumptions are that everyone has this kind of smartphone, where once you put Arogya Setu on your phone and you give Bluetooth access to Arogya Setu and location access as well, then it would. And on the other hand, you're supposed to have a universal kind of record of who has tested positive for COVID. And then basically based on their phone location and your phone location, the idea is that you'd be able to sort of guess whether this person has been exposed and needs to be tested for COVID. So obviously you can imagine that even the way that I'm describing its functioning, you can imagine that it was really not possible for it to contribute very much to the disease surveillance efforts at that time, because actually we didn't even have enough test kits to be able to test the ones who were asking to be tested because they had symptoms. So a lot of the COVID infections went unreported. And on the other hand, of course, at that time, we didn't have, we still don't have very great estimates, but the proportion of the population that had these kinds of smartphones was less than 50%. So even if everyone were to be tested, if they were positive, and if everyone had a then even then, if everyone downloaded the Arogya Setu app, it would not necessarily be possible to use it in an effective way. And then, of course, there was the additional problem that there was a lot of information that the Arogya Setu app was seeking from those who downloaded it. So I've listed them right on top, their name, their phone number, their gender, their travel history, and for some reason, their smoker status. And then the other problem is that it was made mandatory. It was a bit of a free-for-all at that time. Like, the legal framework was not in place, and people were just issuing, so certain residential colonies, they said, if you don't have the app, then you could even, be pulled up and targeted, etc. And then, of course, there were privacy concerns related to it, because at that time, airline staff who had been flying around were being targeted by their neighbors, because the neighbors were scared that because they had been traveling, they would be exposed. So there were those kinds of harms that could result if all this information was made available. At one point, the Indian government, when somebody tested positive, they were pasting a notice outside their homes, also then making the patients vulnerable to being targeted uh, for being positive. So there was a whole range of surveillance and tracking related and privacy concerns arose from the way the app was being forced on various sections of the population. So you couldn't travel from one place to another if you didn't show that you had Arogya Setu on it. I myself had to travel in May 2020 from Western India to Delhi, and I didn't want to download the Arogya Setu app, but somebody told me that they could just take a screenshot from somebody, and if anyone asked me, I could just show the screenshot and pretend like I was good to go. Of course, other people found other hacks as well, the ones who were aware about the privacy concerns. The other one that I wanted to talk about a little bit was CoVIN, which was for the COVID vaccine, and the way it was rolled out. Basically, it amounted to privileging the privileged in the country. So, like I said, vaccination began in mid-Jan 2021, and so the platform was available only in English and Hindi initially. And as far as English is concerned, it's like, according to the estimates that we have, about 8 to 20%, different surveys give different numbers, but the percentage of the population that has any English is very low. It's less than 1/5 of the population. And then the other Indian languages, of which there are many, as you know, were only added 4 months later. So, that itself became a way of excluding a lot of different people, or making them rely on others who would be able to navigate the platform in English or Hindi. The other thing that's noteworthy in the way the CoVIN platform was being used is that it was sort of, an impression was created that you could only register online, or that, those people would be prioritized. And actually, according to the government's own data, about 80% of the vaccinations eventually happened through walk-ins. And the way the walk-in works is that you went to a public health facility, and somebody there would be sitting with some kind of digital device and would register you on the CoVIN platform. So in fact, even the official website, their FAQ, the frequently asked question section, one of the first few questions is, how can beneficiaries with no access to smartphones, computers, or internet manage online registration? So initially, an impression was created that you could only get access to the vaccine if you had access to the internet to register yourself and get an appointment slot through CoVIN. Similarly, it was an impression was created that Aadhaar was compulsory, so you needed to have this unique ID number. This just to sort of help you figure what Aadhaar is like. So it's often compared to the social security number in the US. It's different in some ways. Like it's not like you would get social security benefits if you have an Aadhaar number. But if you don't have it, then you are likely to lose your existing welfare benefits, whatever you might be entitled to, whether it's social security, pensions, or admission into school. So I talk a little bit about that. But basically, just as an impression was created that you could only get access to the vaccine if you were able to register online on your own, an impression was created that, I mean, first of all, you did have to give an ID at the time of getting the vaccine. And here they said that it would have to be the UI, or an impression was created that it would have to be the UID that you would have to submit. And again, on the official um, frequently asked questions page, this was one of the questions, like, can I actually get the vaccine if I don't have an Aadhaar number or an Aadhaar card? They're used interchangeably, those terms. And then the third one that I want to talk about, which is, I think, like the overarching digital initiative, which has this feature of function creep. It started with being, projected as important for improving the implementation of welfare programs, and then it's morphed into all kinds of things. Now it's also being asked for in health related situations. The government of India is currently trying to link. We already have a voter ID requirement, so you need to be a registered voter and you need to show your voter ID card, or at least one of the IDs is this voter ID. But now they're asking people to link their voter ID cards to their UID, the Aadhaar numbers. So the the project, the UID project, has this function creep aspect to it. It's been quite fundamental to all the digital initiatives of the government since 2010. And it was sort of sold as something that would help us create a more robust welfare system and improve inclusion into welfare programs, because actually the budget on welfare programs in India is very small, and therefore that leads to exclusion. But the promoters of the UID project managed to successfully create an impression that exclusion was because people did not have ID documents. And so basically that battle was lost because the matter went to the Supreme Court after the project started. But in 2018, the Supreme Court of India ruled that it was, the whole project was legal and it could go ahead in more or less the manner that the promoters of the project had wanted it. One of the key problems with the UID project is that there is a rhetoric of it being voluntary, but in fact, de facto, on the ground, it is treated as compulsory. And even the Supreme Court of India's attitude towards this, or understanding, has been disappointing, and they've not really been able to fully understand how this double speak, newspeak, we also call it, was used to basically sweeten the bitter pill. As far as, that's our understanding of the issue. And like I said, there were, with the Aadhaar project, with the UID project, there were at least to some extent, people were able to understand that health related data is very sensitive. And so there was some sort of restrictions on using Aadhaar in letter. There were some restrictions on using Aadhaar in the realm of healthcare. And because at least in letter those restrictions remain, we now have something. We also have an NHS in India. It's not the National Health Service, but it's basically a mega digitization project. It's the National Health Stack, which is supposed to be a centralized cloud-based repository of everyone's health records. It has 4 or 5 different components. It will have insurance firms on the one hand, it will have empaneled health providers, public and private, on the other, and it will also have people's health records, their diagnostic results, etc., available. And of course, they say that it is what privacy. There is privacy by design in the National Health Stack, but their own understandings of privacy are pretty limited. And I'd like to talk about a little bit more as I go along. I'll try to speed up a little bit because I think I have 15 minutes more. And what is interesting is that if you look for the National Health Stack, if you just do a simple health stack India search online, the people who are really interested in it are private consulting firms, business media, because really this is actually a way of opening up the health sector to private interests even more in the Indian case. So let me this is just basically a description of the 3 case studies, like I call them, to highlight some of the issues that emerge from them. So the first one that has been most distressing is exclusion of people from a whole range of government benefits. Some of them are recognized as rights. There are laws that guarantee access to a certain amount of food or to school admissions, etc. And when people don't have an Aadhaar number, for instance, then they have been denied access to their subsidized rations. According to a survey that was done some years ago, about 1 million children were denied school admission because their parents were not able to produce Aadhaar numbers. And even the Supreme Court judgment had actually exempted children. It's not meant to be mandatory for anyone, but for children, there was a special exemption. But on the ground, as I said, these are not really taken seriously. But in the case of healthcare, there have, like I said, there have been very serious concerns which were actually recognized by lots of people. And what you find is that because Aadhaar was being asked for when people went to get treatment and medicines if they were HIV positive, some people dropped out of their treatment. So this is from just a news report. A woman who is a sex worker was worried that if she gave her Aadhaar number, then that may be leaked and her family would get to know what kind of work she does. So she just stopped going back to get her medicines. In other cases, women, so there's a government program that provides women with 6,000 rupees for every pregnancy. And again, Aadhaar has been made compulsory to get this very minuscule benefit. This is for women who are not in formal employment like me. I would, of course, get much more, but this is for women who are in the informal sector, in the unorganized sector. And even though it's a really small amount, it means a lot to these women because it allows them just to take a small break, to be able to quit work when they're tired and need rest. But to access the scheme, these women, they need Aadhaar. They run from pillar to post, trying to get to get enrolled. Not only do they need the Aadhaar number or the Aadhaar card, it should also be such that it states the name of their husband rather than their father. So it's very patriarchal. It's always name of the woman, either her husband or her father's name. And if she's a married woman, she's just got married and moved to her in-laws, she hasn't updated her Aadhaar details and she gets pregnant, then she will not get these maternity benefits until she updates not only from father's name to husband's name, but also updates her address from her natal home to the in-laws village. So there are all kinds of devious ways in which these technologies or these initiatives are making it harder for poor people who desperately need government support to access them. There have been instances of women landing up at a hospital in like at the time of labor pains and being denied admission into the hospital, delivering at the doorstep sometimes, and in one case also dying as a result of not being admitted right at the doorstep because she did not bring her Aadhaar number with her. The other is, Virginia Eubanks has this book called Automating Inequalities. And basically, she describes how these digital initiatives were used in the US to make it harder for women to claim. In her case, she's describing the case of women who were trying to access benefits, legal benefits that they were entitled to. And just because the processes were digitized, it became harder for them, knocking out a lot of women. And that kind of thing also played itself out, with all these three initiatives that I talked about, but especially the CoWIN platform for vaccination was problematic. And the Supreme Court also stepped in, and actually, at least in the case of the vaccines, the government was willing to remedy some of the problems that I highlighted, and in fact, they did. But not without causing a lot of pain, meanwhile, to a lot of people. So the Supreme Court of India at that time in 2021 ruled that vaccine policy exclusively relying on a digital platform for vaccinating a significant portion of the population between 18 and 44 would be unable to meet its target of universal immunization owing to such to the digital divide. And it is the marginalized sections of society who would bear the brunt of this barrier. It would have serious implications on the right to equality and the right to health. And I think partly because there was quite a lot of public pressure at that time, some of these policies were diluted, leading to the introduction of those FAQs and sort outlining, what they could do if they didn't have Aadhaar or if they didn't have private access to the internet and to the platform. The other one is the lack of consent and this function creep, where it's meant to be for something and then it ends up being for much more without people really realizing it. So one, of course, very serious issue with lack of consent is that de facto it's made compulsory, and people then don't really have a choice. If you can't, people are not going to walk away from vaccines because they have privacy concerns sharing out there, some of these ID documents. But more seriously, one of the more egregious kind of lack of consent issues that arose at this time is that when people registered themselves on the CoWIN platform using Aadhaar, actually later they allowed other IDs. I didn't have to give my Aadhaar number. I used another ID. But those who used their Aadhaar number to register on the CoWIN platform for their vaccination, a few months later, they realized that the government had automatically generated a health ID for them. Now, this health ID is related to the NHS that I talked about, this National Health Stack, which is supposed to be this cloud-based centralized repository of everyone's health records, which, as you can imagine, creates a very serious data security kind of concern, which I'll talk about. So in June this year, there was a major data breach of the data in the CoWIN, from the CoWIN platform. What the union minister clarified at that time, he said that a Telegram bot was throwing up CoWIN app details upon the entry of phone numbers and data being accessed by a bot from a threat actor database, which seems to have been populated with previously stolen or breached data. Whereas 2 years ago, the person who headed the National Health Authority that's in charge of the NHS had very confidently stated that COVID does not allow the download of beneficiary data. So clearly there is a problem. And what's really frustrating is that there are data breaches time and again. This is the COVID data breach, but it's happened in many different databases that are linked to Aadhaar, whether it's the food related programs of the government or others, and the government never really fully acknowledges the problem. Um, Also very recently, the last bullet point on this slide, there was a cyber attack on the All India Institute of Medical Sciences, which is really like the apex, sort of the most important hospital in the country. It happens to be in Delhi. But the cyber attack basically meant that all these scheduling systems that were digitized had to be shut down for a few days, and there was no kind of backup, and so it really affected the functioning of the hospital pretty seriously during that time. Then there are data mining and surveillance concerns. So because, as I said, this NHS is a centralized cloud-based repository, and there is quite a lot of interlinking of databases. What we worry about is the creation of a digital panopticon that we have already seen in the case of Aadhaar, because if I am a government employee, then to get my salary or to pay my taxes, I need to submit my Aadhaar number. At one point, they were forcing us to link our mobile numbers with our Aadhaar numbers. And from there, God knows where it was shared. We did not have a data protection law in the country until a month or so ago, and I want to talk about that before I wrap up. So there is a very serious problem because data is leaking from all kinds of sources, government and private, sometimes by accident, sometimes because of threats. And as this, this group of researchers at NYU have stated that, and I think they're right, is that the Indian government is basically deciding to outsource healthcare to private healthcare providers and insurance companies. And, our earlier attempts at empaneling them in some of the government-run health insurance programs haven't been particularly successful, because the rates that are offered through those health insurance programs are not remunerative enough according to them. And so now I think there's kind of like, you'll have access to people's data, and perhaps that's that's the carrot that's being used to sweeten this pill. So maybe I'll skip that one, and maybe there'll be an opportunity to talk about it later. But this slide was basically to say that there isn't that enough awareness and understanding of the privacy related issues. Basically, the way people talk about it certainly amongst the economists, is that this is an opportunity. When there's so much digitization, there's like data lakes, and then we can just monetize this data, and a lot of people will benefit from the data market. But then it's also spun as something that will enable health related research and AI and all of that. And the last point that is of concern with the emphasis on digital healthcare, is that it is displacing more important health efforts. And again, I thought I'd just bring in some data here. So the number of nurses per thousand population in India is just 1.7 compared to 7 in Brazil. Even South Africa is better off on these two metrics at least. Again, hospital beds are woefully inadequate. And like I said, until recently, we didn't have a data protection law, but the law that was passed in the last session of Parliament last month is basically a very weak kind of law. And it's trying to create it aims to create a framework for legalizing data mining and data sharing. rather than focusing and having protection of data as its core concern. So it's very different in many ways from GDPR. And in any case, GDPR, as you know, there are worries that it's become a bit of a paper tiger, because as far as these big corporations are concerned, the fines that are imposed by the tribunals or commissions are basically now being treated as operational costs of business, and they just pay the fine if it ever comes along, even though to us as laypersons the amount seemed really large. In actual terms, for the companies, it's like 1 or 2% of their uh, revenues. And so the last point that I want to make is that, at least in the Indian case, we find this is a very different kind of battle that we're faced with. One aspect of a lot of these digital initiatives is that they are funded by philanthropists. And the Bill and Melinda Gates Foundation, especially in healthcare, is a huge operator. They're funding PhD scholarships at the best universities. They're funding even something in The Guardian on development reporting. So there's a kind of capture of all the institutions. The other problem is that there is this techno-utopic approach in India, especially amongst the policymakers, and anyone who raises questions is labeled a Luddite, and they say they want to throw the baby out with the bathwater. These are just, and then if they do acknowledge some of the problems, then they say, oh, these are just teething issues. But in fact, even 10, 12, 15 years after these like Aadhaar began, these teething issues have not, this is a baby that's not growing up at all. And even when other tech-based solutions are offered, they're not interested. They want centralized databases. I think the purpose is to enable data mining and profiling, etc. And so what's happened is that between these philanthropists, who also actually come from the tech world quite often, but the two big players in the Indian scene are BMGF and Omidyar Network, and the techno-utopic approach of Indian policymakers, it seems like both are sort of pushing in the same direction, which is to weaken democratic processes and to disregard the need for political solutions and to just focus on technocratic solutions. So I'll stop with that. Sorry, I've gone on a bit longer than I meant to.
All right, thank you. So as I mentioned earlier, if you have a question, we have about 10 minutes, but you can either say it and I can sort of repeat it, or you're welcome to come up here so that our speaker can hear you. Don't be shy. We all know each other at this stage. Does anyone want to come up and ask a question? Everyone might need their coffee this morning. Oh, you might need a coffee this late in the evening there. Yeah, we've got.
I had a coffee a couple of hours ago.
You did to make it through the evening?
Yeah.
I'll
stop sharing? Maybe?
I'll stop your sharing so that we can see you. Louise is coming.
Is it possible to turn the screen around so I could see?
Yeah. Oh, Louise is coming.
Hi, thank you very much for an excellent presentation, and really what my question is basically that I thought it was quite interesting the way you sort of decided to get round not signing up for the and making sure that you weren't a victim of data leaking by the technique you did by taking a screenshot. I was wondering what kind of the population would it be? A less educated population that were kind of drawn into signing up or to this mandatory process? And what do you think are the consequences for these population, apart from what you've just already underlined, but in terms of data leaking? Do we have concrete examples? You said that there was concern by the sex worker, etc., but Do we have any examples that also in the press or elsewhere of what this has had, the effect this has had on these people that signed up to this mandatory process?
So I think one for things like tuberculosis, HIV, where there is some stigma attached, those patients are the ones who are at risk of dropping out from their treatment and therefore their health being affected because they're worried about privacy and losing control over their data. The other big thing is exclusion from quite a lot of other benefits. So, the fact that many children, for instance, if they don't have their Aadhaar ID documents in place, may be denied admission to school. It means that they will not have access to the school meal program. And these are students who are in any case coming from very poor socioeconomic backgrounds and therefore poor nutrition at home, lack of access to adequate food. And the school meal often is an important supplement and complement, whatever, to what they get at home. So there are different ways in which their health can be affected, whether it's through access to food and nutrition programs or directly to health related programs. But you're exactly right that for the poor population, any form of government support is so important that they will do anything to continue to get it. So if the government says that you have access to A, B, C schemes right now, government support programs right now, and you can only continue to get that support if you submit all your ID documents to us, then these people will do it because they cannot afford to lose access to these benefits. So that they end up doing whatever is required because of the nature of the precarious nature of their current economic or socio-economic status. And so now they've lost control over their data if the government is not careful enough and if it leaks. So there have been some instances of loan sharks, basically, trying to give them, trying to identify people who might be vulnerable and trying to sell them loans, give them credit, and then people get stuck in that cycle. In fact, I mean, this is not related to healthcare directly, but I can give you one example, which was a big racket. There were apps available from Google Play Store that you could download on your phone, and you just give some information and they say, okay, you're eligible for a loan. And then actually when you are downloading that app, the loan app, it's also asking for access to your contacts, your gallery, your photographs, etc. And then these people, after they've been given a loan, they keep pestering them to repay, and certain terms and conditions which were not stated up front are now made known to them. Then when people are unable to meet the deadlines for repayment, they use morphed photographs that they got access to when the app was downloaded, and they start threatening these people and saying, we will send this to all the contacts on your list. And these are compromised photographs that have been morphed. And so there were a couple of suicides that happened in one state. And that's how the police got onto the case. And then the central bank in India kind of asked for these apps to be removed from Play Store. So this nature of the regulatory system is so weak in India that even if in letter there were some legal protections, whether the poor would be able to access legal recourse is and now we fear that these same kinds of dubious operators will also enter the field of healthcare. Like, if you have sensitive health related information on people, then we worry that it will be misused. And that's why this excessive digitization is a concern.
Okay, thank you.
Does anyone else want to ask a question? Well, with that, I want to say thank you to our plenary speaker this morning. Very interesting presentation, and thank you for staying up for us and getting the day off to a good start here. We have our coffee break now, and I'll ask you all to, as I usually do, reload your programs. I've had a couple of changes. Let me know if you have any questions or if you seem confused, I can help out. But thank you all.
Bye. Thanks for this.